Welcome to the program, Breaking the Barriers in Medication-Assisted Treatment for Opioid Use Disorder. This program is supported by an educational grant from Alkermes, Inc. and sponsored by the North American Center for Continuing Medical Education. My name is Dr. Arwen Podesta. I'm an assistant professor of psychiatry at Tulane University. I'm medical director at ASAR LLC, and I'm owner and psychiatrist at Podesta Wellness. Also, I'm president of the Louisiana chapter of the American Society of Addiction Medicine. Here are my disclosures. I will be discussing off-label use of medications in this presentation, and I will identify those medications. Brand names will be included for participant clarification purposes only. These are the learning objectives. We're going to outline the current evidence supporting the use of medication-assisted therapy, we're going to call it MAT, to improve outcomes in opioid use disorder, or OUD. Evaluate available and emerging long-acting formulations of OUD pharmacotherapies with respect to their mechanisms of action, efficacy, safety, routes of administration, and regulatory and access considerations for appropriate use. Describe the specific needs, barriers, and considerations of OUD treatment in special settings, including the criminal justice system, Veterans Health Administration, inpatient and outpatient facilities. Implement strategies to overcome barriers to effective implementation of MAT and OUD management. During the presentation, if you have a question, please feel free to type it in the question box in the lower left corner on your screen. We will address all questions during our live Q&A sessions in the last 20 minutes of the presentation. Okay, let's begin with this case. So this is a 36-year-old married female, mother of two. She's been in active alcohol recovery for 15 years. She had a tennis injury, and then she had surgery, and she was started on opioid pain pills as prescribed for 6+ months. She was stopped on the prescription by her doctor. She got sick, didn't really know what was going on. She figured out it was the pain pills. She asked friends for pain pills, and she actually was able to get friends, family, and associates to give her pain pills from their medicine cabinets for 6 or more months. Then she found herself tapping into some of her resources in 12-step, actually, people that knew people. She started buying pain pills off the street, and then the economy of that, she found that heroin was cheaper. So through her dealer, over several years, she migrated from pain pills from friends to pain pills from the street, then to heroin. Then she sought treatment at IOP, intensive outpatient programming, which is where I met her. She was started on buprenorphine, 2 milligrams, 2 a day, so a total of 16 milligrams a day. And then she finished her IOP level of care, and she ended up in outpatient care. We changed the medication from buprenorphine 2 daily, so 16 milligrams, eventually slowly over to the injectable Naltrexone. She then relapsed on opioid pain pills after missing a dose of Naltrexone, Vivitrol, and then we started on buprenorphine again, and then to outpatient buprenorphine, and then extended release injectable Naltrexone again, which is where we are now. So there's 2 common pathways to getting into addiction and then recovery and treatment. So first, starting with pain treatment, which is what this patient experienced, but then she graduated to the second entrance, which was the illicit recreational use. Some people may start with illicit recreational use, but either way, people develop physical dependence and tolerance, and then they have withdrawal. If they stop, but as continued use occurs, there are psychosocial and behavioral changes and actually brain changes that occur, and that is opioid use disorder. And then someone at some point in their activation of their recovery will seek acute intervention or just stop on their own. And then there's often, relapse and acute intervention phases, and then they might get into long-term treatment and long-term recovery, and then relapse may occur again. So these are the multiple ways of getting into and out of addiction use and addiction treatment. ASAM, short definition of addiction. I want people to remember this because this is important. We have a chronic disease here. Addiction is a primary chronic relapsing disease of brain reward, motivation, memory, and related circuitry. And if you disrupt these circuits on an ongoing basis such that you have addiction, it leads to a characteristic biological, psychosocial, social, and spiritual manifestations. And so that's how we then see people with addiction. People get stigmatized with addiction because oftentimes they will end up having pathological means of pursuing their reward, i.e. perhaps criminal or some sort of illicit activity, in order to continue to use the substance. We know this is a problem. Everyone on this call is quite well aware that we have this problem. This is a 2014 article in the New York Times showing the slope of the curve of drug deaths rising. If you extrapolate out to today, and it's higher, as you all know, and it's regionally different, but it's hitting all of us. There's been a long history of using abstinence-based treatment, which works for some, and I will show you that it works for some in this slide. However, we are facing a deadly disease here. When someone relapses on opioids, no longer are we worried about a slip and then get back into treatment eventually. We're really worried about death. And so because of the access to fentanyl and because of the complications of all of the multi-drugs being put into the street drugs, fentanyl, benzodiazepines in conjunction with whatever else is there, can really be a very big risk for overdose and death, or overdose and morbidity, not just mortality, which is equally as troubling. So abstinence-based treatment does work. I'm not against abstinence-based treatment, except when we're trying to prevent death and help people stay in treatment. And this study was from 2015, and it was presented. It wasn't published, but it really rings true with what we see through and through. In an abstinence-based treatment setting of, let's say, in this slide, 242 patients in residential treatment, after they're released from residential treatment, 34% relapse within 3 days. And for those of you that work in jail systems or in other systems where people are abstinent and they are, they might not be getting treatment, but they are abstinent, you know what the relapse rate is within 3 days. It's higher than this. But in this treatment setting, 45% relapse within 7 days, 50% within 14 days, and 60% within 90 days. So great, 90 days, we have 40% of people that didn't relapse. That's great, but in some studies, when we have a relapse, there's a good percentage of people that have overdose and mortality or morbidity, and that's one of many, many concerns. So approximately 2/3 of patients in abstinence-based programs relapse after they complete their programming. Well, there's some discussion about why they relapse and what can we do. And we're here to talk today about pharmacotherapy treatments for opioid use disorder. So it really does come down to that brain chemistry that we're talking about in the reward system. And for people struggling with opioid use disorder, OUD, there's opioid receptors that are uncovered. And so when I'm talking with my patients, I talk about what we're going to do to kind of put the helmet on the opioid receptor, because that is basically like a preventive tool to help protect the opioid receptor from craving the opioid and from, if you do use the opioid, from having detrimental effects with that opioid. So I'm going to move over to medication-assisted treatments, and I really want to show you some brain chemistry stuff. So this is a great slide that I created using lots and lots of data from Dr. Stahl and from Dr. Volko and all these fantastic researchers. But this is a kind of a conglomeration of a lot of their work. So everything in red is a drug, is something that's used illicitly, essentially, or used for a reward in addiction. So what I'm trying to show here is that we have drugs that hit receptors, and they work specifically. They have mechanism of action in the reward cycle of the brain. They hit receptors, and then we have medicines that hit those same receptors, and maybe not as extremely volatilely, causing a large dopamine spike. But that is why these medicines work. So I want to touch on nicotine because this is something that patients and family members can attach to, because everyone knows someone that smoked. Everyone knows someone that smoked and that quit 15 times and that finally decided to take a medicine, varenicline, known as Chantix, or bupropion, known as Wellbutrin or Zyban. And you can see that varenicline, it hits the nicotine receptors at the ventral tegmentum where dopamine is stored and then shot out. And that's why varenicline works. It's specifically modulating the dopamine tone at the nicotine receptor. Bupropion is Wellbutrin or Zyban is specifically a dopamine reuptake inhibitor. And that's why those two medicines work. I'm not going to go into all of the other medications and drugs listed on this slide, but I want to refer to the top right at the opioid receptors because that's where buprenorphine, methadone, and naltrexone work. Therefore, we are basically working on the same set of receptors that the drug is working on to help fix the problem, to help calm the cravings. I would like to note medication-assisted treatment is the lingo that's used. That's what's been adopted. Medication-assisted recovery is a great set of words as well that will be kind of more useful. That's the way I like to think about it, that we're actually recovering people. We're helping people get into a recovery and a meaningful lifestyle. So let's move on to other types of evidence-based treatment, because I don't want to forget that medicines are just one tool in the toolbox. As a psychiatrist, when I'm treating a patient with depression, I definitely don't only give a medication. I make sure that people are making lifestyle changes, referring to therapy. Sometimes we use other mechanisms as well and get the family involved. But as far as addiction treatment goes, these are evidence-based treatments. Motivational enhancement and contingency management are great. The matrix model, which a lot of residential and intensive outpatient programs use, it's evidence-based. Cognitive behavioral therapy is a phenomenal tool, and it is also evidenced and has great outcomes. Community reinforcement plus vouchers, there's some communities that do really well with this for addiction treatment. Family behavioral therapy. Getting the family involved is paramount because it's like changing the language in the house or with the loved ones. If one family member is struggling with addiction, it's not necessarily a family disease, but it's affecting the family greatly. And so family behavioral therapy is very important to augment addiction treatment or to help addiction treatment last. Mutual help, all mutual help is fantastic. 12-step, Narcotics Anonymous, Alcoholics Anonymous, Refuge Recovery, Smart Recovery. Those are mutual help groups, and there's lots of others that are out there in your region. Be sure to have a list of referrals for your patients. 12-step facilitation is something that a therapist can do to essentially help facilitate someone to get into self-efficacy of 12-step. I cannot say enough about the importance of intensive referral. So imagine you have a patient at a primary care office and you are the first person to discover through motivational enhancement and good clinical evaluation and SBIRT that you need to refer them to treatment. So the RT and SBIRT is referral to treatment. So you need to refer them to treatment. If you hand them a card, they're very unlikely to go on their own to seek out help. They have a bond with you, but you help bridge that bond by doing an intensive referral. If you or someone else in your office is able to, the best thing is to either, we can do this in some settings, have an admissions person either on the phone or come into the primary care setting, for example, and see that patient so that they develop a bond so that then they will come with them. And that can be done with recovery support staff in the hospital setting if you arrange it. Some really great programs, particularly in Florida and the Northeast, are utilizing that. What I do, because I don't have the facility to do that in some of my practices, is a phone call with the patient in the room with the approval of the patient, and then I pass the phone to the patient so that the patient can at least develop a voice bond and commit to a plan to meet someone, either if it's a 12-step meeting or meet someone at an intensive outpatient programming for an admission, et cetera. So intensive referral is very important because just handing someone a card is very unlikely to have good outcomes. Pharmacotherapy, you'll notice pharmacotherapy that I was talking about in the slide before, pharmacotherapy is just one of the many tools in evidence-based treatments, but that's what we're going to talk about today. What are medications for opioid use disorder used for? Certainly detoxification. People have seen patients detox or heard stories of patients detoxing from opioids, and it's not pretty. And patients will say that they would rather die than go through detox again, which is why they continue to sustain using oftentimes. So it is not a deadly withdrawal, but it feels like death. So what do we use? Well, we can use an opioid agonist, methadone. We can use a partial agonist, buprenorphine, or we can use like a mimicker of and use a taper. So tramadol is used. It has been an occasion. Patients like it. It doesn't have that many studies on it. And then there are also comfort meds, and you can use comfort meds with or without the above opioid agonist, partial agonist, or tapers. So the comfort meds are comforting to your blood pressure, to your gut, to sleep, to your anxiety, which are all symptoms of opioid withdrawal. Lofexidine is actually a brand new FDA-approved medicine. It's a blood pressure medicine for opioid detox. Clonidine has been used for that same reason for years, and tizanidine also, and propranolol also. But lofexidine is the only one that is actually FDA-approved for opioid detox. In conjunction with the blood pressure medicines, you might want to use gabapentin. Both it helps with anxiety and the muscle spasms that come with opioid withdrawal. Benzodiazepines are commonly used. Some places choose not to use those, which is fine. GI medications, and then sleep medications. Also, the NADA technique, the National Acupuncture Detox Association technique, which is 4 needles in the ears, and it seems to help calm down the fight or flight, the sympathetic nervous system occurrence. And with that in that same vein, electrical nerve stimulators, which is an auricular device, such as the bridge, that's FDA approved to sit on the ear for a period of time, 5 days, in order to calm that fight or flight down. What about maintenance? Now that we're done with detox, then we need maintenance to put that helmet on that opioid receptor. And some people go through detox and just move right into abstinence, and that's what I'm worried about. So after detox, I want to do something for maintenance, for craving reduction. Methadone, which is a full agonist, buprenorphine in the forms of Subutex, Suboxone, Zubsolv, Unavail, Sublocade, and Naltrexone in the form of oral Naltrexone, or Vivitrol, the extended-release Naltrexone. Okay, I'd like everybody to go ahead and take your first polling question. In your opinion, which patients with OUD should have access to MAT? Select all that apply. Patients with OUD in the criminal justice system, patients with OUD in the Veterans Health Administration system, patients with OUD in inpatient facilities, patients with OUD in outpatient facilities. Okay, getting back to those three types of medications for OUD maintenance, opioid receptors are what I keep talking about. So there are really only 3 things that hit the opioid receptors. And if you think about a receptor biologically, what can you do to the receptor? If that's the place, if the receptor complex is where you're working biochemically, biologically, what can you do? Well, you can turn it on, you can turn it off, or you can partially turn it on and off. That's it. So the methadone is the top one. That's a full agonist, meaning it turns the receptor on full time. Methadone works great because it works like it is a full agonist opiate, So is morphine and heroin and OxyContin and all of those. But it is a very tight binding and long-lasting medicine. So for those of you that have known people on methadone, you know that they take it once a day, but if they miss it, then it really lasts for a long time in their system. And so what it's doing is it's covering the opioid receptor. All of these are covering the opioid receptor. And then when someone slips up and takes a pain pill or takes heroin, the opioid receptor is covered. And so the heroin or pain pill doesn't bond at the opioid receptor. It might bond a little bit if they're not taking enough of the medicine, which is why we push the doses to a proper higher dose than some people think is comfortable. But that's why we want patients to be on a proper dose, not bargain with their dose. Buprenorphine works as a partial agonist at the opioid receptor. So it kind of, I liken it to turning it on and turning it off. So kind of a dimmer switch. Only at the receptor is it a dimmer switch, not related to dopamine per se. And then opioid receptor antagonist, the blocker, naltrexone is a blocker. Naltrexone being in the form of the oral or the extended release. Naloxone, i.e. Narcan, the opioid overdose rescue, is also a blocker, and that's why it works, because it's a blocker at the opioid receptor. Okay, so these are exactly what I'm talking about, the effects of full agonist, partial agonist, and antagonist. So this gray kind of Pac-Man is the opioid receptor, and they're sprinkled throughout the brain and body, but when we're talking about the reward system, that's in the ventral tegmentum and the nucleus accumbens, the system that I showed the kind of the close-up view of with the medicines and drugs earlier. So a full agonist is the opiate or heroin, and that sits fully on the opioid receptor, binds to it, and turns on the dopamine fully. And you can also add methadone to that list because methadone does the same. It just does it in a tighter bond and a longer time frame. Buprenorphine is the partial agonist, and that kind of has that point taken out of the triangle there. And so it does sit on the receptor. It turns the receptor partially on, turns the receptor partially off. So we get a partial effect. And then naltrexone is the opioid blocker. And so that covers the opioid receptor, but it does not turn it on. Next, I'm going to move into a comparison of these three types of medicine treatments for opioid use disorder. So this is a study in 2003. It's a pinnacle study that was looking at buprenorphine versus placebo. I get asked all the time, less so now, but certainly when I started doing this 8, 9, 10 years ago, I was always getting asked by family members and loved ones and patients too, how long am I going to be on this medicine? When I would put someone on buprenorphine, how long am I going to be on this medicine? So this study was showing a 1-year study of patients on maintenance buprenorphine, and the other arm, the gray arm, was patients on placebo. And so the gray arm showed people that detoxed on buprenorphine and then they came off of it and went into abstinence. And the purple arm is showing people that were maintained on maintenance dose of buprenorphine throughout the 1-year study. And everyone received counseling. Everyone was a similar matched cohorts on each side of the study. There were only 20 people in each arm of the study, but on the maintenance arm, about 75% were still in treatment and on buprenorphine by the end of the year. In the placebo arm, the detox-only arm, every single person by about 60 days had relapsed. And unfortunately, and this is why this placebo study is no longer ethical, unfortunately, at that time in 2003, 4 of those people in the year were found to have overdosed and died. So 4 out of 20 in this study in that year of the placebo arm overdosed and died. So when patients are asking me or parents are asking me, how long are you going to put this patient on this medicine? Doctor, how long should I expect to be on this medicine? I don't know, because I know that you need a lot of life changes before we're going to take the helmet off. So this is an evidence of that since 2003. And so, but what about methadone? Because methadone is another good treatment. And so This is a comparison from 1992 between buprenorphine and methadone. Now, for those of you that work in the methadone communities, you'll see that it says that high-dose methadone is 60 milligrams a day in that light blue color arm. High-dose methadone is not 60 milligrams a day. That's actually kind of a medium dose. 20 milligrams is definitely low dose. But anyway, so what I want to look at is comparing what I would call a normal dose of methadone, the blue arm, and the purple arm of buprenorphine. And the first slide is over 16 weeks, or the first graph actually is over 16 weeks, how many patients were retained in the study. And retention is an important piece. So those with buprenorphine and methadone high dose were similarly retained. Anywhere between 60 and 70% were retained in the study, and so methadone was slightly higher. And what I would surmise is that methadone and I don't know this from the study, but what I see in patients is that people in methadone clinics, they have the social positives of going to the methadone clinic on a daily basis for a period of time, and so they have an improved connectivity with social groups and with positive, non-isolating events. Whereas on the right-hand side, we're looking at the urine samples, so the mean negative urine samples, and really, ultimately, at the very end of the study at 16 weeks, the high-dose methadone and the buprenorphine were neck and neck, 40% and 39%. So that looks really good. So this is the outcome of the study. This is basically the conclusion of the study. Both medicines, buprenorphine and methadone, are highly effective. Buprenorphine has a higher safety profile, which that wasn't relayed in those graphs. They both reduce opioid use. They both reduce mortality. Methadone has a better retention rate. Results regarding opioid use are mixed. Some studies favor buprenorphine, some favor methadone, but the study that we're looking at is pretty clear-cut in what we see overall. And the context and the setting of treatment is different, at least here in the U.S., because we have opioid treatment programs, methadone, and I was mentioning that that's where they have the pro-social component, versus an office-based practice. And so a buprenorphine prescriber can see a patient and just use a medicine and not all the other treatment parts. And so the patient can go in for quote-unquote discrete treatment, and they don't get the pro-social aspect of treatment. But they don't have to go to an OTP where they go every day. There's a buprenorphine implant. It's not widely used, but it is available. It's basically similar to a contraceptive implant that people are familiar with, and it has a 6-month slow-release buprenorphine. It's for people who have been on 8 milligrams a day of buprenorphine for a while, and it certainly has some issues. But it is available, so I wanted to make sure that everyone knew that was available. Regarding sustained release injectable buprenorphine, which is Sublingual, it was FDA approved November of 2017, and it's a monthly injectable, 300 milligrams a month for 2 months and 100 milligrams a month. It's a great medicine. We get the monthly injection, and it improves adherence, reduces diversion, and reduces unintended exposure. And frankly, when someone has been using particularly pain pills or heroin on a daily basis, maybe TID dosing, 3 times a day dosing, but with, falling off and seeking it and having to go get more, they've been putting this external reward. And so they're used to putting something in their mouth to get a reward, having this thing externally, and then putting something in their mouth or a needle or snorting, however they're using it, to get a reward. And so if you can uncouple that behavior from the reward and from, things like pain management, for example, you can really make a vast improvement in cravings and in behaviors, which is why the sustained release injectables are fantastic for patients, and patients do really like them a lot. This is the phase 3 study of the sustained release injectable buprenorphine, and so it was a 6-month study, and the success rates are at the bottom. So the success rates for the 300 milligrams monthly and then 100 milligrams after the first 2 months were 28%, which is not that good, 29% for the 300 and 300, which is not great, but it's certainly better than the placebo, which was 2%. So, this is a tough disease to treat, but it's very important to know that we can have some good improvements with medications. This is a study showing sublingual versus implant buprenorphine. So the first piece of the study is actually the implant versus placebo, and that's showing the retention for the implant was 64% and 26% for placebo. For opioid-free weeks, 64% on the implant and too many dropouts for placebo. So too many dropouts ends up being not an okay part of a study. So we moved to the sublingual versus the long-acting implant. So the bottom part of the slide shows retention, 64% for the implant, 64% for sublingual buprenorphine, and opioid-free weeks, 31% for the implant and 33% for the buprenorphine. Frankly, I must say when we're talking about opioid-free, that doesn't necessarily mean success, because so frequently when someone is on a good medicine, they're gonna push the envelope. And frankly, I think they should, as long as there's no bad outcomes. I would never tell a patient, because that shows them that the medicine's working. Oftentimes, a patient might be on an injectable or a sublingual or a medicine that's working, and they'll slip up. They run into someone that they used to know, and they're, so they slip up. Whatever, they slip up, they come back to me, they're scared that they're going to, go back to jail or have me fire them, which I would never fire a patient. I would move them to a different level of care. But if they slip up and they know that the medicine's working, then that uncouples that seeking of the reward, that now the medicine is working and the drug isn't working. Okay, this is the extended release injectable naltrexone for opioid use disorder, and it was naltrexone versus placebo. And so the retention on the naltrexone, the monthly naltrexone, was 53% versus 38% on placebo. Total abstinence without any slip-ups, total abstinence on the injectable naltrexone, 36% versus 23% placebo. Okay, another one. So this is the oral naltrexone, daily 50 milligram oral naltrexone versus monthly 380 milligram depot injectable naltrexone. So days retained, the depot 42 days retained versus the oral 32 days retained. And 100% opioid-free urine, 52% in the depot versus 37% in oral. So what I'm showing you with all of the above studies is that all of these are better than placebo. Medicine, MAT, is better than placebo. And it seems that longer-acting medicine is better than shorter-acting medicine as far as outcomes go. This is an XBOT study that's a multi-center study by NIDA, so not pharmaceutical company sponsored, that looks at Buprenorphine-Naloxone daily versus extended-release monthly naltrexone. And the study was a little bit hard to get people into, because when you randomize people into a study and then you have multiple centers doing detox, some people might not be eligible to go from detox from heroin or full agonist opioid directly to naltrexone. So we'll talk about that in a minute. And so they may have been maintained onto the buprenorphine instead of the naltrexone, even though when they were randomized to the naltrexone arm. Among those that were inducted, the rates were equal as far as how long they lasted in the study and what the outcomes were. So what the XBOT study shows is both medications are equally effective. And starting extended release naltrexone is challenging because it requires detox. We have to be in opioid abstinence before we put a blocker on the receptor. So we have to find optimal ways to get patients from opioid, full agonist, partial agonist, to then using naltrexone. So this is another study that is looking at oral naltrexone versus extended release naltrexone. And at the bottom, you'll look at the extended release naltrexone group had a better outcome than the oral naltrexone group, 57 versus 28%. Really, what we know is that none of these medicines are inferior to each other. And like I said before, the longer acting the medicine, the better it seems to work in patients. Some of my psych residents, when I teach addiction to prescribers, I always talk about why we would choose one medicine, an agonist as in methadone versus a partial agonist as in buprenorphine versus an antagonist as in naltrexone. There's good reasons for patients to take each one of these medicines. Access and availability are key. So the thing is, if you have someone that lives far away from a methadone clinic, but they really want to take methadone, but they don't have transportation, they're not a good candidate for it. If there's no buprenorphine prescriber in your area and a patient gets out of the hospital on buprenorphine, they're not going to be able to get buprenorphine. So looking at access is key. If their insurance doesn't cover methadone, which some states doesn't, then figuring out how to get them into something that they have access to. Agonist therapy, methadone, is prescribed only at OTPs for addiction. It's Schedule 2, and it has to be at a treatment setting. You do not need detoxification before starting the agonist therapy. Partial agonist therapy is Schedule 3, buprenorphine. It can be done in an office setting. It does require a prescriber to have a specialized X number, a specialized license, and it does not require detoxification. In fact, it can be part of the detox process. Antagonist therapy, naltrexone, also can be done in an outpatient setting. It does not require a DEA license, and so someone without a DEA license but that does have their prescribing license can prescribe it. It does require detoxification. So there's benefits to all of these. Let's go back to RJ. So remember I had talked about in the middle, she went from IOP, she was on buprenorphine, she went from IOP to OP, and then we changed her from OP, in OP, outpatient, from extended release buprenorphine. We stepped her down to injectable naltrexone. And then she relapsed. She went through detox again. They put her on buprenorphine again, and then we had to transition her again to extended release naltrexone. So let's talk about how we can do that. What do we do to move her to naltrexone? We've always thought that we needed 7 days off of a full agonist opiate like heroin and 2 weeks off of methadone or more before we started naltrexone or the extended release naltrexone. But we have these protocols that have been put out in the last couple of months and years that decrease that from 4 to 5 days down to 8 days that make it successful so you can get people onto extended release naltrexone within 4 to 8 days. All right, polling question number 2. How would you move RJ from buprenorphine to extended release injectable naltrexone? Switch directly from buprenorphine to extended release naltrexone. Taper buprenorphine, then switch directly to extended release naltrexone. Taper buprenorphine with low dose naltrexone, then switch to extended release. None of the above, just continue buprenorphine. And I hear that, and patients want oftentimes to get onto the extended release naltrexone, but they have a hard time switching, and the doctors sometimes don't have the tools to use. So we're going to talk about those tools. This was a study by Manelli, and it was released at it was a poster presentation at ASAM this year. So basically, they used low-dose naltrexone plus a buprenorphine taper. The outcomes with low-dose naltrexone plus a buprenorphine taper versus placebo naltrexone plus a buprenorphine taper were pretty much similar, and 46% of patients were able to get onto the extended release naltrexone within 8 days. What they did is they used buprenorphine in lower and lower doses, plus comfort meds as needed, with or without low-dose naltrexone, and they were able to transition 46 and 40% of patients onto the extended release naltrexone. It turns out that if people were held steady on maintenance buprenorphine for 8 milligrams or less, they actually had a better profile to get onto the extended release naltrexone in a quick buprenorphine taper to extended release naltrexone in less than 8 days. This is a great naltrexone induction algorithm that was published in 2012, and it's been used over and over, and this is with the low-dose naltrexone. So using the low-dose naltrexone on day 3 or 4 at 6 milligrams BID or 3 to 6 milligrams QD to BID, and then a naltrexone injection, usually after a naloxone challenge, will get people being able to be on the extended release naltrexone in 6 to 7 days. So treatment is a complex and multifaceted thing. So these are all the details that we just discussed, different types of medicines, how to move from one medicine to another, why choosing one medicine versus another. But we need to have a whole bunch of things in order to treat the disease of addiction. A chronic care approach is really a paramount way to think about this disease and treatment. So multimodal, no cookie cutter approach, multiple courses of treatment may be required for success. 3+ months minimum, the longer the better is what we see. We need to expect relapse. So for those who fire patients when they relapse, I'd like to undo that, because it's a chronic disease. We wouldn't fire a diabetic for having their glucose elevated on one visit after whatever happened. We need to have a whole slew of complementary approaches from an X number DEA waiver, therapists and counselors, community-based peer support programs in the area, and then knowing we need that continuity of care, which is like detox, inpatient, partial. So whatever you're not at, knowing who you can refer to when the patient needs to go up or down a level of care. We do have lots of barriers to care. We have lots of patients that need treatment, but they don't recognize they need treatment. And so the demand may not be there, which is where the primary care and ERs come in, really doing SBIRT and educating patients that it's a chronic relapsing illness. Providers need to be trained more, and thank you all for coming to this, because we need more knowledge, willingness to treat this disease, and we need more access to supportive services and more people getting their X numbers and using them with the comprehensive services. The system, we have a huge stigma against this disease. This disease has been considered a character flaw for a long time. We know there's biological parts of it, and we know there are characterological parts to it, but we also have hurdles to get medications, get these addiction patients out of my ER, or get these addiction patients out of my pharmacy, or I don't want to be a hospital that treats addiction. We have continuum of care problems, and reimbursement is certainly a significant problem that a lot of us are facing. Same with society. There's a lot of misinformation. Regulatory constraints are key. So buprenorphine, you can only get buprenorphine from a DEA waivered physician. There are some caveats. ERs can write, hospitals can write without that, but oftentimes they don't want to because they don't have training. Methadone, only DEA registered and working in OTP can provide methadone. And naltrexone, extended release naltrexone, anyone can prescribe it, but people really need to be trained and have administration. The nurse or administrator needs to really know how to do the injection. Okay, thank you very much. We're about to move to questions. Okay, thanks everyone for listening to this and coming to this opioid use disorder webinar. This is Dr. Podesta, and I have with me on a panel Jacqueline Cleary, PharmD, Leanne DeMondradon, nurse practitioner, Judge Jody, I can never say her last name, Sawalski, and Adam Rivas, LPC, all of whom are experts and hopefully can answer some of your questions. So I'm going to go ahead and get started with some really common questions that you may have and you may be thinking. So I kind of touched on this on the webinar, but the first question I'm going to direct to Adam, and then everyone else can chime in. Patients are always asking, or patients' families, why should I replace one drug for another? So Adam, would you start talking about that?
Absolutely. What I usually try to educate patients on is the idea that you're not replacing one drug with another. The drugs of abuse, they have a very reinforcing factor. We start educating clients about the dopamine reward cycle and things like that, and they can get the idea of why they're continuing to do cocaine or heroin or alcohol and things of that nature, not to mention the physical component alone. But when you get on something like naltrexone or Vivitrol, you're not exciting that system, and so there is no reward for it. And in fact, when you start really explaining to them how that process works, they can start to understand that it's doing the opposite that their drug would do, and not rewarding them and helping them to control their cravings and manage how they feel a little bit better in relation to wanting or craving a drug. And I find once I get into that kind of thought process with them and explanation, they seem to understand it and get away from the idea of thinking that they're replacing one drug with another, which is a very common thought.
And I try to also use the word medication for a medication-assisted treatment that is not that roller coaster of the up and down that the drug use is. And so I use drug for those that are used illicitly, and I use medication for those that are not. Another question, and this is to the whole panel, how do you approach patients who are resistant to lifestyle change and clearly just want medication-assisted treatment? Maybe Leanne, why don't you start, because you're in this in an outpatient family practice clinic.
Right. So initiating medication-assisted treatment is it's such a valuable tool, but it's also not delivering the lessons they need to learn, which would come through treatment or attending Narcotics Anonymous or AA, depending what they need. And so getting the support that they need outside of alone with the medication it's giving them that free space to be able to learn those tools while they're still living in recovery. And so basically it really needs the secondary support with it. And, working in an outpatient setting, sometimes you just need to use what's available by the community or where you can get them into an intensive outpatient setting if they're reluctant to go to treatment especially.
And Jody, do you have, Judge Jody, do you have comments on that question too?
Well, I think that when we're looking at it from the perspective of the judiciary, I like to affectionately call it coercive treatment. And, there are phasic systems that need to happen. And it's interesting, some of the questions that you've already brought in, that requires some real education on patients and lifting the stigma first, because they feel so much shame from being in front of the court, and we have to get them to recognize that first that there is a disease state and that they in fact can recover. And so besides the educational components and just quite frankly the power of that unflattering black dress, which says, hey, you haven't been successful in your decision so far, let's go ahead and hit this from a medicinal component but also a behavioral component. And furthermore, and I think one of the most powerful things to impact that sort of ideology, that disease state ideology or pathology, is the use of mentors to really convince them, and again, through all of these different systems, we really coerce them into that treatment and behavioral health component as well.
Great. I want to ask Dr. Cleary, PharmD, can you talk about the best approaches for patients who are on MAT who also want to use medical marijuana?
Sure. So this question I get a lot, and I would say it's very provider and institution specific. And then you get into the question of harm reduction. So what is the lesser evil from a literature standpoint? Unfortunately, we don't have a lot of data in terms of what the interaction is particularly, and there is some stuff coming out now with using some of the CBD or THC products, whether or not it's medicinal or not, can cause some issues in itself, particularly in this population. So I tend to not recommend it, but I have worked with MAT providers in the past that if you're working on harm reduction and your patient is not using their illicit substance, but they are occasionally smoking marijuana, some say that that's okay. So I don't really have a clear recommendation for that. It's going to be what the provider is comfortable with, but right now we don't have a clear, if there is a drug interaction between the two.
Yeah, and I'm going to make a mention of that. There are some providers in some states that have large recovery institutions or large recovery facilities that are just taking marijuana off of the screen, and I don't have anything to say about that one way or the other, but in states where it's been legal and medicalized and also legalized for a long time, some providers are taking it off the screen. One question, is diminishing medications to zero always the goal? Actually, Jody, from a legal standpoint, when you're talking about patient care under kind of coercion for starters, would you talk about what the goal is?
I'm sorry, you cut out there, Arwen. Did you say?
I'm sorry. Are we trying to get people off of medication-assisted treatment? Is that the goal? I know in the judicial system, a lot of times that is
right.
The stated goal, but
well,
from a treatment perspective, it's not.
again, the disparity, every single judge in every single jurisdiction is going to have a different answer to this. And unfortunately, there's best practice standards for medication-assisted treatment, especially for opioid use disorders that have come out of the National Drug Court Institute that are starting to catch on and create some real precedent in those best practice standards. However, we still have a huge part of the judiciary that doesn't even believe that addiction or substance use disorder, opioid use disorder is in fact a disease state, and they really don't understand the neurobiology of addiction and things of that nature. So that's a very, very broad question. And what I can suggest to you is that, in my own practice and in my own treatment courts up here in Michigan, it's really a harm reduction strategy, and obviously there are different forms of medication-assisted treatments or treatments that are used that involve medication for, this disease state. And no, it's not always to be completely substance-free in that regard. However, I would suggest to you that in the majority, and to the people listening, most judges are going to want you to be abstinent and completely drug-free, and getting beyond that standard where they're even entitled to the use of medication-assisted treatment in treatment courts around the country is still a battle that we're facing, and there's certainly going to be some challenge under the ADA for that. That's a very long-winded answer to a question, so I apologize.
Yeah. And this is Dr. Podesta. I'm going to chime in because the goal really is treatment, and so understanding how someone is going to function off of a medicine, off of something kind of protecting the opioid receptor, whether it's a full agonist, partial agonist, or antagonist,
right?
And taking them off of it only when they're ready to come off it and have all of their other lifestyle and psychosocial tools. Just like with an antidepressant, taking someone off an antidepressant once the trauma is resolved and they've gone through therapy and their lifestyle has changed and their nutrition status has changed, then maybe we can bring someone off an antidepressant. But I wouldn't give a deadline for that. Let's see, Leanne and Adam, can you speak to, and also Jacqueline, can y'all speak to the question, what is the average length a person might remain on buprenorphine or methadone for that matter, or Vivitrol for that matter?
Yeah, I prescribe Vivitrol. This is Leanne. I like to tell people because that's a very common question, like how long do I need to be on it? I like to give people this kind of, one is as long as you need to be on it, but two, to get the tools, but also looking at I like to get people through a major holiday, a birthday, and whatever could come in between that, because that's when people get together. You might have some of your triggers. If there's anything situational that can come up in between that, but I like to. So, and that starts looking like about 6 months. When you're just starting, just as a conversation. As far as length of time, I kind of just try to put that in their radar, so they have some sort of game plan themselves for the continuity.
And then, Adam, what do you say to your therapy?
Yeah, I try to prepare clients for the same idea. About 6 months is usually what I see people do with the Vivitrol injections, and that's after they may have been on the pill form for about a month or so. But I also think it's very individualized. During that time period, people should be trying to build up more resources and ways to help keep themselves sober for when they come off the med. And sometimes clients aren't prepared for that. So I have seen people go longer in some instances, and that's usually, between themselves and their physician and what the doctor thinks is best, and also what if a therapist is involved, our input is also asked for sometimes as well. But 6 months with the shots usually what I've seen, and I've seen people stay on the pill form for a longer amount of time than that before as well. But like I said, for me, most of the time, I tend to see these things always very individualized to the needs of the client, where they are in treatment, do they have legal situations, et cetera, et cetera, et cetera. So it's again, all very individualized.
And may I just chime in on that a little bit? This is Jody.
Yeah.
I just think it's really important to remember here, because what we're seeing is a very diverse team on this panel. And from the judicial criminal justice perspective, we have to remember that judges have timelines. and statutes are put in place. So, you know, in some states, for example, in a misdemeanor situation, we can only hold an individual for 2 years. And the probability that someone's going to hold them even in a treatment court situation for more than like 12 to 18 months is probably about average, you know, 5 years typically in most states with a felony. So they're looking at those timelines as well. And so that factors into when and how they're going to push and graduate through the treatment court process. But not only that, this whole example right here and some of the things that you stated right there, I did a publication where my JD meets your MD, right?
Yeah.
Or your PhD, whatever the case may be. This just compels, I mean, this just, again, reinforces the importance of having an extremely diverse treatment team that includes medical practitioners, MAT specialists, things of that nature on that team as well, so that they can really guide the judge in that decision-making process.
And for those of you, I know those of us that work in treatment settings where we might see patients that are also engaged in the criminal justice program, it's very useful to reach out and be part of the treatment team, even if the criminal justice program might be a little bit resistant to that, and so that you can help your patient. You can help your patient best. I want to address one quick question. What is the data for the number of patients who benefit from 12-step programs? Really quickly, the ASAM, the American Society of Addiction Medicine, mentions that about 10% of individuals who join a 12-step program are in recovery after 5 years. Now, that doesn't mean that the other 90% don't benefit from it greatly. So I talk about it, and Adam, can you talk about how you tell people how to get into, how to find a 12-step program?
Usually I do a lot of referring to folks, giving them the resources that are out there on the internet. It's finding 12-step programs is pretty easy. Finding the right one for a person can be difficult. And that kind of gets back into one of those first questions about lifestyle changes that we had. And when you get involved with those, there's a whole different lifestyle that people have to be willing to take on, and a philosophy as well. And that, I think, causes some of the issues folks have with adapting to a 12-step program or that lifestyle. It can be difficult to change what you've been doing for 20 and 30 years or, you know, at a drop of a hat. And so I think that's why you get some of the numbers you got. But with finding the availability, I mean, it's very easy to find. It's all out there on the internet and within the community once you know some folks out there. So referring folks to it is simple. Explaining it to them and having them and kind of embrace it or really work into it is where I find a lot of my work comes into play, because, like I said, you're totally changing your entire lifestyle in favor of a new one. And as much as we all want to do that, sometimes it's not all that easy to do.
And just keep going is what we tell patients, and also making sure that you as a provider or as someone in the treatment community knows the resources, like Adam said. I think the next set of questions are kind of piggybacking on each other. So Dr. Cleary, I'm going to ask you to start this one, and maybe Leanne, you can chime in, and Jody too. What's the best approach to patients on MAT who have an acute pain problem, and then how can those how can those who are managing patients on these medicines that have trauma, how can they control pain? And I can chime in too. So Dr. Cleary, will you start that?
Yeah, sure. So in an acute pain setting, the first question is, what type of pain are we treating? There's a whole host of non-opioid adjuvants that can be utilized, anything from anticonvulsants, pregabalin, gabapentin, to NSAIDs, you know, high dose, maybe even ketorolac injections, ibuprofen, naproxen, utilizing Tylenol, acetaminophen. Another practice, buprenorphine comes IV. You can give an IV dose of buprenorphine in the emergency room or for pain control. Methadone IV in acute pain is not usually a safe option. So typically what we do in my institution, if someone's being maintained on MAT, is to continue the same dose. But because these drugs have such long half-lives and their pharmacokinetics are such that if you stop the drug, it's still going to be in the patient's system, we actually keep the same dose but spread it out a little bit. So rather than methadone once a day or buprenorphine, Suboxone once a day, we actually will take the same dose, divide it up to maybe QID or 4 times a day dosing, to divide that antagonism of the opioid receptor, and then supplement in, say, if it's a trauma or a surgery patient, some IV morphine or oxycodone or whatever, your institution's using. So there's a whole host of things. Some institutions are even using ketamine, an NMDA antagonist, so not even, again, at the opioid receptor, but can also help with some pain relief. So there's a lot of different strategies, but the biggest thing is to have a plan and to not think that the MAT therapy is going to be treating the patient's new acute pain.
And Leanne, can you speak to when someone's on Vivitrol and they have an acute pain incident?
Yeah, I exactly use the tools that she was talking about, the medications. I'll put people on short courses of gabapentin, depending on the type of pain. And I do also use muscle relaxants. I find tizanidine is very helpful. And also if they're, and also I find around pain there's a lot of anxiety, so treating the anxiety around it to actually help soothe them as well. And also there's some, the gabapentin can work as a mood stabilizer. So, and then I have put people on Lyrica if they're more chronic to try to help, soothe a longer condition while they're still on these treatments. And then just being a medical provider, getting up underneath the source of the pain and sending them to physical therapy if they need it. But oftentimes just addressing the anxiety around the pain is, as a dual combination, is very helpful.
Right, and so pacing activities are very important, making sure that people don't try and go all the way with all of their activities when they're in acute pain, but also, like Jackie said, understanding what the type of pain is. If it's an emergency pain management and someone's on buprenorphine or methadone or injectable naltrexone, they are the paramedics and EMTs and emergency room people are all quite well aware of how to override the opioid blocker or the opioid partial agonist in order to get good pain management if they have to go into the OR for something like a quick surgery or something like that, or emergent surgery.
Yeah, and on that note, just quickly, every time somebody comes in for their injection, I always kind of give them ask them to show me their wrist, to carry either their necklace or their wristband to make sure that's on at all times.
Perfect.
In the event of yeah.
And Dr. Podesta, one thing I did mention, non-pharmacological options, they can get a nerve block. They can get injections. So there's some other pain management options. Even inpatient nerve blocks are great to manage pain, even if they're on MAT.
And I have acupuncture in one of my offices, and we use that a lot too, not for emergent pain, but for acute though. And that can be really useful, or other ancillary non-medical procedures as well. I want to ask a couple of you if you can chime in about the common question that males ask, which is regarding sexual performance and any of these medications from the full agonist, partial agonist, or antagonist.
I get that question a lot when I deal with a lot of my male clients, and they it is a very big concern for many of them. But usually, again, through education and a little bit of research, we're able to kind of help people along with understanding that that's not really going to happen with drugs like naltrexone or Vivitrol. With other drugs like Suboxone or buprenorphine, my knowledge is a little more limited on that one, but I typically tend to work with clients who are on the naltrexone or the Vivitrol. And so with that, again, like I said, just through some education about how the drug works and how it affects the body, and that tends to help the person when I'm counseling them. And then also whatever they happen to learn from their physicians as well, to kind of do some patient education on those things, it usually helps them out.
That's great. And from a physiological standpoint, some people do find that they have some dysphoria with an opioid blocker, but that's a very small percentage, and it's very likely that it's related to a dysphoria that may have been underlying before they started taking the opioid. And so as psychiatrists, we can treat, dysphoria and dyspleasure. It doesn't necessarily translate into a sexual performance issue, but there is a common myth it's a common understanding that a very small percentage of people do have dysphoria and anhedonia, and in fact, even some suicide risk with new Vivitrol usage, but then we just treat that. And so I think that's really useful. We are going to wrap up, so I want to thank the panel very much. I think this was a great, robust discussion, and thank you everyone that attended for submitting your questions. You'll receive an email in just a few days to receive your credit for this, this CEU. Thank you, everybody.
Thank you.
Thank you.